Welcome to the deep dive. You're probably here because you want to get up to speed on ischemic heart disease, IHD, pretty quickly, right?
Exactly. Get well informed without wading through dense papers.
We've pulled together some key info, really focusing on the epidemiology, like who gets it, the risk factors, and the pathophysiology, how it actually happens in the body.
Yeah, the mechanics of it.
Our mission today is simple. Just boil it down to the essentials. What is IHD, who's most affected, and why does it develop?
Sounds good. Where should we start? Epidemiology.
Let's do it. What's the big picture with IHD prevalence?
Okay, so IHD is pretty much the leading cause of cardiovascular issues globally. It's very common.
Right.
And what's interesting and maybe a bit concerning is that it can often be there without any symptoms at all. Silent myocardial ischemia, they call it.
Silent. So you wouldn't even know.
Potentially, yes. And that silent phase can actually be an early warning sign if it's caught.
How would they even detect that then?
Well, doctors have a few tools, things like continuous intracardiac monitoring, sometimes checking metabolic markers near the heart, looking at hemodynamics, blood flow factors.
Okay. And if it is found, what's the approach?
Optimal medical therapy is key. Usually involves getting the heart rate down, managing blood pressure, and sometimes, procedures to open up blocked arteries, revascularization.
Got it. And the underlying cause. What's actually going wrong in the arteries?
It boils down to two main processes: atherosclerosis.
The hardening and narrowing.
Exactly. And thrombosis, that's blood clot formation. Those are the big players.
Okay. So who is most likely to experience this? You mentioned epidemiology.
Right. The demographics are quite telling.
Wow.
Overall, the male-to-female ratio for IHD is roughly 2-to-1.
So twice as many men.
Overall, yes. But it changes dramatically with age. If you look at people under 40, it's much more skewed, like 8 men for every 1 woman.
8-to-1. Wow, that's a huge difference.
It is. But then look at the other end of the spectrum, folks over 70, and the ratio drops to almost 1-to-1. It really evens out.
What causes that shift? Why does women's risk catch up?
It seems strongly linked to menopause. Our sources highlight that the incidence in women actually trickles after menopause.
Triples. Okay, so hormonal changes seem pretty critical there.
Definitely suggests a protective effect before menopause, which diminishes afterward, bringing their risk level closer to men's in older age.
And when do symptoms typically show up? Is that different too?
Yeah, there's a pattern there as well. Men tend to present with symptomatic IHD, chest pain and such, more often in their 50s and 60s.
Okay.
For women, it tends to be a bit later, more commonly in their 60s and 70s.
So important for women, especially post-menopause, to be really aware of their cardiovascular health, even if it wasn't maybe top of mind earlier.
Absolutely crucial. Vigilance is key.
Okay, so age and sex are major factors. What else increases someone's risk?
The sources list quite a few. They break them down into non-modifiable, the things you can't change, and modifiable.
Right. What are the unchangeable ones?
Age, like we discussed, sex, and having a family history of early heart disease. Those are sort of set.
And the ones we can potentially do something about.
That's a longer list, as you'd expect.
Oh.
It includes hyperlipidemia, high cholesterol.
Yep.
Hypertension, so high blood pressure. Diabetes is a big one. Smoking, of course. Psychosocial stress.
Interesting.
Yeah. Also obesity, not being active, a sedentary lifestyle, drinking too much alcohol, poor diet, and also having elevated lipoprotein.
That last one, lipoprotein, maybe less well known, but important.
It is. And the source material specifically flags high cholesterol, high blood pressure, diabetes, smoking, and family history as particularly significant.
Okay, makes sense. A lot of familiar factors there. So let's get into the how. How does atherosclerosis actually develop? What's happening step by step?
It really starts with some kind of injury or dysfunction of the endothelium that's the inner lining of the artery wall. Think of it as the first domino.
Okay, an initial trigger.
Exactly. This injury attracts immune cells, specifically monocytes. They travel from the blood into the artery wall, and then they transform into macrophages.
Right, the cleanup crew, usually.
Well, here they get involved in a less helpful way. These macrophages start modifying LDL cholesterol, the bad cholesterol, turning it into oxidized LDL, or OXLDL.
Oxidized, so it's damaged LDL.
Precisely. And this OXLDL is readily taken up by the macrophages. They essentially gorge on it.
And what happens then?
When the macrophages eat up all this OXLDL, they become what are called foam cells. They look foamy under a microscope.
Okay, foam cells.
These foam cells build up, and that accumulation forms what we call fatty streaks. That's really the earliest visible stage of an atherosclerotic plaque.
So injury, immune response, cholesterol uptake, foam cells, fatty streak, what next?
Then, various chemical signals like cytokines and growth factors get released. These cause smooth muscle cells from the artery wall to move into the plaque area and start multiplying.
Some more cells piling in.
Yes, and these smooth muscle cells, along with other components, form a fibrous cap over the lipid-rich core. This creates the more developed plaque.
So you get this cap covering the fatty core. What determines if that plaque becomes dangerous, like if it ruptures?
Good question. The risk of rupture seems to depend on a few things. One is the balance of enzymes. Some enzymes, protease, can break down that fibrous cap, making it weaker.
So more breakdown enzymes, more risk.
Generally, yes. Also, the amount of dead cells or necrosis within the plaque core contributes to instability. And even the location matters plaques forming, where arteries branch, bifurcations, experience more stress, and are more vulnerable.
That makes intuitive sense. Areas under more physical stress. Okay, let's try and summarize this then. IHD is a huge cardiovascular problem, number one, really. It's often silent, driven mainly by atherosclerosis and thrombosis.
Yep, artery hardening and clots.
Men get it earlier, typically, but women's risk shoots up after menopause, evening things out later in life.
A very key point about menopause.
We have those risk factors. We can't control age, sex, genetics, and many we can influence, like diet, smoking, blood pressure,
A
cholesterol.
lot of lifestyle factors, definitely.
And the whole process starts with artery lining injury, leading through immune responses and cholesterol buildup to form plaques, which can eventually rupture.
That's a great distillation of the pathophysiology, yes. Injury, inflammation, lipid accumulation, plaque formation, and potential rupture.
So thinking about all these interconnected pieces, here's a final thought for you, our listener. Given how many factors feed into IHD, from our genes to our daily choices, if you had to pick one type of change, what do you think could have the biggest positive ripple effect on heart health for a whole population?
That's a tough one. Makes you think about prevention on a